병원 저기 원무과에 가서 돈을 내야지 응급처치를 해줘. 그런 것도 불만이고. 이렇게 병원에 가서 이렇게 말을 하려고 됐어요.
누가 책임져야 합니까?
택배 물건처럼.
비싼 약이기 때문에 지금 보상을 안 하겠다는 거냐.
당신 같은 거 하는데 필요 없어. 나가!
The cafe has become an arena for Korean patients who are fighting to protect their rights against hospital, pharmacies, pharmaceutical companies, the government, and local administrations. The patients have started the Patient Shouting Cafe as a hub for open communication in the medical and healthcare field. Here, the patients shout out their troubles and complaints, find healing in consolation and sympathy from the audience, and seek wisdom for finding solutions to their problems. The patients are free to pour out their hearts about their sufferings, complaints, and wrongdoings committed by various stakeholders.
우리 예강이가 어떻게 자기가 죽게 되었는지 원인이라도 알고 또 다른 예강이 같은 피해자가 없도록.
문제는 이 약이 한 알에 16만 7,500원이래요. 하루에 2알을 먹어야 되는데 그러면 한 달에 약값이 1,000만 원이에요. 약이 뭐 잘 들어도 걱정, 안 들어도 걱정이에요. 잘 들어줘도 막상 또 처방받으려면 한숨만 나오고 돈 때문에, 약값 때문에 치료 못 받는 게 진짜 너무 서글프고 이게 누구를 위한 약인지.
정말 사소한 실수로 주사기를 잘못 잡는 그 실수로 아깝게 목숨을 잃는 경우가 없었으면 좋겠고요. 그 희생으로 미흡한 제도가 제발 고쳐졌으면 좋겠습니다. 그래서 앞으로 치료받아야 할 우리가 좀 더 안전한 세상에서 살았으면 좋겠습니다. 직업이 기자라면 기사로서 써주시고요. 의사라면 의술과 정직한 양심으로 치료를 해주시고요. 정부라면 정책으로 각자의 자리에서 자신의 사명으로 용기 내서 세상을 바꿔주셨으면 좋겠습니다.
There's an advisory committee that consists of medical doctors, lawyers, and patient group representatives, and it suggests solutions to the issues raised by the patients at the cafe. Following these suggestions, the patients try to seek solutions together with KAPO. At the Patient Shouting Cafe, the patients find tremendous comforts and healings in empathy and support from the audience. Journalists also take part to report on the medical and healthcare agenda discussed at the Patient Shouting Cafe. This forms public opinion, thus leading to the making of important regulations, policies, and laws. We were able to learn that patients can have their voices heard through the Patient Shouting Cafe to become an important healthcare public agenda. When patients and patient groups participate in the process, healthcare regulations, policies, and laws can be changed to become more patient-centered.
Hello, I'm Carol Bennett. I'm the CEO of Australia's leading peak pain advocacy body, Pain Australia. And we work to improve the life of people living with pain, their families and carers, and to minimise the social and economic burden of pain on individuals and the community. We've been working with our federal government here in Australia to inform pain management policy at some of the highest levels. Recently, there have been some major reforms rolled out, and Pain Australia has worked with our broader consumer network to inform some of these changes. In June of this year, the Australian government rolled out major reforms in an effort to reduce the harms of opioid use. We've seen this around the world. It's not unusual, and unfortunately, though, these reforms have led to some significant distress for some people living with chronic pain, whose medications have been taken away and there are limited alternative options available. At Pain Australia, we agree that opioid harm is an important issue. And we know that around the world, governments have grappled with the issue of how to minimise opioid-related harm. However, pain is a complex condition, and we can't just focus on prescribing alone and restricting medication use as a potential solution to managing that harm. Unfortunately, these changes were rolled out in the middle of a pandemic and at a time when many consumers in Australia were already feeling quite anxious and quite exhausted by the bushfires that we saw in our summer in early 2020. Over the course of the past couple of months, our office has been inundated. Since those opioid changes came into place, our staff, along with the chronic pain community and prescribers, have been caught in the impact of these significant reforms. We've had to respond to distressed phone calls, emotional emails, and messages on our social media channels. But the impact on Pain Australia and our staff is incomparable to the on-ground reality of people who previously had access to opioid treatments now being left with completely inadequate alternative options. Pain Australia and other pain management stakeholders have been engaged with the Department of Health for a number of years to seek to inform the design and the development of opioid reforms, how they're managed, how they're communicated. No one doubts the need for more judicious prescribing of opioids. The evidence and the research is clear, but we do need to minimise the harm associated with opioid prescribing while still making sure that we've put in place alternative options and that these changes are very effectively and clearly communicated to consumers and prescribers. We all know that you can't just stop prescribing opioids, particularly when they are the cheapest, most readily accessible form of treatment for people living with pain conditions, without doing something else to help them to manage their condition. We know also that medication is just one aspect of a much more complex treatment regime. And if we don't address the complexities of chronic pain, there's real potential to actually cause harm. It's the reason, pain is the reason 3 million scripts are written in Australia each year. There's been a lack of adequate education and awareness. Not everyone knows what pain conditions are and how to manage them. And we know that in Australia we have 3.37 million people living with chronic pain. There's many barriers to accessing pain treatments, costs, waiting times, proximity to treatment. These barriers are real and often insurmountable to a person who lives with complex chronic pain. Many people simply have no access to alternatives, and that's what they're telling us, and as they reach beyond a point of desperation. So we've always said that in the reform of opioid medications, we should also make sure that there's a national strategic approach to pain management. We've developed a national action plan in Australia, one of the world's first national action plans, which sets out the blueprint for what needs to happen in pain. And we've seen some traction on this plan. Of course, during COVID, the implementation of that plan has taken a back seat as the nation has rallied to deal with the unprecedented public health challenges of COVID-19. But we're hopeful that Australia's health ministers will come to the party and implement this national approach. We did some surveying of our consumers. Within a number of days, we had hundreds of consumers telling us their stories. And we found that the lack of a coordinated communication strategy to support what is a significant reform to opioid medication availability was a big issue, and the lack of accessible, affordable options for the management of chronic pain. And we also found that mental health is a significant issue for people grappling to live with chronic pain. So, in summary, I think we really need to wake up to the real costs of neglecting chronic pain. We've seen incalculable harms of getting these policies wrong. We need to learn important lessons from countries like America that have seen bad situations get worse because of poorly implemented reforms. It's impossible, it's reckless, and it's cruel to keep ignoring the real issues here. We've got a lack of properly funded and resourced alternatives to medications to manage pain. Chronic pain is not a high priority issue, and it's complex. So we know that governments grapple with this condition and with what to do about it. But we also know we must be holistic in our approaches to managing pain. Otherwise, it will not be effective. We can't just keep cherry picking these problems and focusing on half-baked solutions that are poorly implemented. This needs urgent resolution. We've recommended that these reforms be supported by a targeted communications campaign that's consumer-driven and that can address some of this negative sentiment, and to expedite activities that are outlined in our National Strategic Action Plan. Just as there are no one-size-fits-all solutions for chronic pain, there's no single policy reform that will fix the enormous toll that chronic pain exacts on our community. While we'd like to see a strategic and a comprehensive approach to chronic pain, we recognise that even small steps can make a big difference when it comes to providing some real relief to people who are grappling with accessing appropriate care and support. In today's landscape, ensuring there are replacement treatment options to the ready availability of medications that really are, for many people, a staple treatment, an accessible, affordable staple treatment for pain, is not only what is needed, it's the moral responsibility of our society, and we have to do better. Thank you.
Palliative care before COVID-19 happened was the Cinderella of health services. In the full spectrum of healthcare, where you've got preventative, curative, rehabilitative care, palliative care was the poor cousin. It was always under-addressed, was understaffed and under-resourced. It was one of those services most patients had great difficulties because they had to use it one time or the other. And it was inadequate in what was available as way of health services, but also what was available by way of pharmacotherapies and other treatments. During COVID, we saw this really exacerbated because pain management and pain itself was already in midst of a pandemic, and that was the opioid crisis. We had legislator after legislator slapping regimes which overnight removed a lot of pain relief medication and support. There was a reluctance to ensure patients had alternatives. Patients were left with no information and no resources, and patients were left in really deep crisis, and especially within the oncology side. I think that brought home some of the real damaging aspects, that many of the human rights of these patients were violated. The pain and suffering it brought about was enormous, and I think we need to now say never again. We know that Carol has mentioned very clearly that we do require evidence-based frameworks in the future. Please do not have a knee-jerk reaction and put the handbrakes on some of these palliative care services, because we do not need this kind of interference and this kind of disruption of healthcare services. Please involve patients when you make such decisions. We now urge everybody to reconvene this story, reconvene in the pain spectrum, make sure we have a fresh look at palliative care, and ensure that we have the adequate support that we need for patients, a holistic support, and more importantly, let's look at the pharmacology of pain relief and pain management, and see if we can put in better, more patient-centric and well-regulated and monitored legislative frameworks that can ensure that patients can have that access to timely, accurate, and quality information that they need, and that's relevant to their particular case, and at the same time, they have got safe medication that is dispensed to them in a patient-centric manner and at their own choice and not at the choice of legislators, and that no one is left behind in this equation, that we do restore these services and bring them up to par with everything else past COVID. Thank you much.
My name is Mercy Annapurani from a small town called Virudhunagar in South India. I am a COVID survivor. I had already diabetes for the past 10 years and blood pressure also. So, in the month of August this year, I had the symptoms of COVID. I came to know from the television about the symptoms. So I volunteered myself to get diagnosed in the government hospital. When I went there, they said it might be a normal fever. So they gave me some tablets, paracetamol tablets, and asked me to come after 3 days. After 3 days, when I went there, they said they gave me some more tablets, then asked me to come again after 3 days. So in this way, there was a delay in the diagnosis itself in the first stage. And when I came to know I was tested positive for COVID, immediately I was admitted in the government hospital where I stayed for nearly 21 days. I was admitted not in the hospital building. We were all the COVID patients were admitted in the local schools and colleges, places where they asked us to stay for 21 days. And the treatment was so poor. We didn't know. I have double master's degree, but still I didn't know what tablets they are giving me, which tablets is for which infection. So without knowing that, I had to take diabetic medicines, COVID medicines, and blood pressure medicines also. And I'm already on insulin also. Having to take such a lot of dosage of medicines, there was no nutrition in the food what they gave. They gave us just the normal steamed cake, rice steamed cake, which is full of carbohydrates. So this actually affected our health. We were always sleeping. I don't know whether they gave us sleeping pills or not. We were always sleeping, and almost 20 days, 21 days, there was trauma feeling. We couldn't talk to each other. There was no counseling. We didn't talk to each other with other fellow women also. And once I came out of the hospital, I had to stay in self-quarantine in the home. So I prefer to stay in the office itself. But to my shocking, when I went there, there was a big barricade in the gate, in the front of the door, and a big notice was stuck on the wall telling me the name Mercy Annapurani, COVID patient, under self-quarantine. So everyone who passes by that road stood there and read that one, and immediately they went away from that. So the stigma and discrimination was so strong and so heavy. We are all very much affected by the stigma and discrimination. Then being a woman, it was an additional burden also. When I came back home, my family members themselves, they were not ready to accept me. Most of that time I was to be in the kitchen itself, cooking for them, cooking for the family. So they want to keep a social distance, which for me, it was like stigmatizing me. I couldn't talk to my husband or children. They want to keep away from me. But at the same time, I had to cook everything for them. I thought it was a domestic violence, asking me to be inside the kitchen, cook for them. And naturally, it is our natural thing. All the women here in India, we eat only the leftovers. What the family eats and what they keep, we have to eat that one, which is not nutrition at all. So even in the house, we are not able to get any nutritious food. And the domestic violence in the form of words, in the form of scoldings, all affected me very much psychologically. So what I thought is, even for a woman like me, this experience was very, very traumatizing. So what I thought is to organize women like me who had COVID, to organize ourselves, to speak for us, to speak, to get good treatment. We want nutrition. We want financial resources. So we want to unite ourselves and be a voice to the voiceless COVID patients in India. And we are looking forward to share our experiences to other COVID women in other parts of the world. Thank you.
Thank you, Mercy. You have really put across your point of view very clearly and reassured us that we must look at how patients with chronic conditions who contracted the virus managed to overcome it. It's a story of hope, and it's a story that reassures us that COVID-19 isn't the end of all things that we know. It is a minor aberration in the history of time, and that there was life before COVID-19 and there'll be life after COVID-19. Mercy's story puts two things across to us very clearly. Firstly is that we must have timely, accurate, and relevant patient information out there. This is important because the speed at which we need to diagnose some of these conditions, especially in patients with multimorbidities, is really important. Secondly, what Mercy has put across quite clearly was that the treatment that you're then offered, the support that you're given, should also be very patient-centric. It should look at all the aspects of your requirement. It's not only about the physical symptoms and the distress to deal with, it's also the social welfare support when you're isolating. This is something that's come through all the cases that we have heard of, that our health systems reassured us that they knew us well and they knew where we were. But unfortunately, when the lockdowns happened, many of them left us in the limbo. We did not have support. We did not know how to shop when you're isolated. Not everybody has got a computer at home and online shopping, and not every restaurant delivers to your home. That's something that's come out clearly. And I think one of the hashtags that I followed very closely in India and elsewhere was lockdowns without plan. I think that's something that we need to address in the near future, that patient engagement in all public health interventions is a must. We must be engaged from the right at the outside, even before the first announcement is made, that we need to know how our patient voice is heard and how patients are catered for within this COVID-19 pandemic situations. This is not the first pandemic we will have to encounter. I think in the near future, anything that comes at us, we should be prepared. We should have no excuse left whatsoever to be in the current situation where patients were isolated, didn't know what was going on, scared, and therefore unable to address. We need to look at this afresh, and Mercy has thankfully brought us to that point and really put across that viewpoint that really needed. Thank you, Mercy, and thank you, everybody. Please stay safe. Relief is on the way. I thank the industry for having got us those vaccines, and I think it's only a matter of time before we all join the first batch of vulnerable patients who need to be vaccinated quickly. Do take advantage of these programs, and let's have a great 2021. Thank you.